and welcome back. So for the 8th installment in this series, we're going to analyze the different waves on the normal EKG, and then we'll kind of move forward from there. So I know that this is somewhat difficult without pictography, but if you're here, you probably already have an introductory view into this, and this is going to be more for study time than anything else. So the normal waves that are represented on the EKG are the P, the Q, the R, the S, and the T wave. This was named so because everything else was named A, B, C, D, E, or 1, 2, 3, 4 in science at the time that Einthoven was really coming out with this. So he used P, Q, R, S, T, and it's just always kind of stuck there. So the P wave represents atrial depolarization. The top part of the heart depolarizes, and you get this small little hump. The QRS complex, so the Q, the R, and the S wave, all three are included in here together, represent ventricular depolarization. And this is going to be a lot larger because it is actually a lot more muscle, so there's more electricity. The T wave itself represents the repolarization of the ventricles. Now, the question is commonly asked, well, if I can see the repolarization of the ventricles, why can I not see the repolarization of the atria? And the answer is that it's hidden under the QRS complex. And EKG works a lot like the radars that police officers use to clock how fast you're going. It can only clock the fastest car. In the case of the EKG, it can only register the highest amount of electricity. That being so, the repolarization of the P wave is hidden under the QRS complex. And frankly, it's not a lot of electricity anyway. It would be very difficult to detect. The P wave itself is usually very little electricity. Okay, so let's talk about some of the intervals in between each one and why things happen that way. The very first one we want to talk about is the PR interval. So this is between the P and the R wave. And this is the time that the impulse takes to travel from the bottom of the heart to the top of the heart. So from the atria itself to the ventricles itself. And remember, as we talked about in earlier lectures, it's supposed to be this way. There's supposed to be a maximum of 1/5 of a second of a delay in order to allow the atria to completely empty into the ventricles to get that cardiac stretch and get that better beat, that harder contraction. Remember Starling's law of the heart. The QRS interval is the time that is necessary for ventricular depolarization. So this is the time that it takes for the entirety of the ventricles to depolarize and under normal circumstances contract. The ST segment is the isoelectric line, elevated or depressed in certain disease states, but usually it follows a regular pattern, as you should have seen on some of your stuff. The QT interval is the total duration of ventricular depolarization, and if the QT interval is prolonged, there's increased risk of certain ventricular arrhythmias and subsequently sudden death. This is where we kind of come into the refractory periods, where you have an absolute refractory period and a relative refractory period. And what that means is during the absolute refractory period, the heart cannot be caused to depolarize under any circumstances, versus the relative refractory period, a strong enough stimulus such as, we'll say, a baseball hitting the chest could be enough to cause the heart to depolarize. And this early depolarization at this part of the refractory period of the heart could actually result in ventricular dysrhythmias like VTAC, VFib, torsades if the chemistry is right, and certain things like that. So we'll kind of move forward with this. During the ST segment, myocardial infarctions produce changes in the ST segment itself. They can cause it to elevate, they can cause it to depress. And these are sort of broken down into three main categories. You have a waveform that is represented by ischemia, you have a waveform that is represented by injury, and then you have a waveform that is represented by the actual death of the cells, or the cells that are dead and things are moving through. So there are also areas of the heart that correspond to sections on the 12-lead EKG. So to give you a good example, leads 2, 3, and AVF correspond to the inferior wall of the heart. Leads 1 and AVL view the lateral surface, as well as V5 and V6. If you think about it, they're over there on the left-hand side of the chest. And if you think about it, leads V1 through V4 view the anterior surface because they sit right on top of it. They sit right on top of the heart, and leads function in a similar method to a camera does whatever their direct connection to the surface of the heart, that's usually what they're going to view. And this doesn't necessarily count for the first 6 representative leads in a 12 lead, because they kind of go about things a little bit differently. If you've gotten deep into Einthoven triangle, you understand that. But for your precordial leads, or V1 through V6, they function very close to a camera in that they sit right on top of the part of the heart that they are monitoring. So let's cover some rules. So when you are going to interpret a rhythm strip or a 12 lead ECG, there's some rules you need to follow. You don't really get to a point where you can just look at it and say, oh, this is whatever condition. The biggest one is you have to be consistent in the way that you analyze. So this is the first rule of everything. If you have a process, you need to utilize that process in order to be sure that you're not missing anything. So what does that even mean? What it means is you look at your waveforms, you look at your leads, you look at everything in a very consistent manner that works best for you. So one of the ways I do it is I look at the waveforms first. First thing I do is look at a rhythm strip before I even look at a 12 lead. So is there a P for every QRS? Is there a QRS for every T? Are the waveforms normal? Is the PRI interval normal? Is the QRS duration normal? We're going to cover that towards the end of this video. What normal is what we're going to cover. So this type of stuff is very important, and you need to develop a habit. You need to develop a system. It's okay to develop one on your own. There's also templates out there that kind of tell you things in a certain way. So we're going to cover that now. So analyze first your rate, the rhythm itself, right? So the rate, is it between 60 and 100? Is it above 150, as will be the case in certain supraventricular tachycardias? Is it above 200, as it is in some extreme cases? Analyze the rhythm itself. Is it regular? Is it regularly irregular, right? Is there a PVC every other beat? That's regularly irregular because the irregularity happens on a regular basis. Or is it irregularly irregular, as in the case of atrial fibrillation? No QRS complex is the same distance from the other one because the atria are fibrillating and the bottom of the heart's just kind of contracting when it gets an impulse, right? When it gets around to it. Check your P waves. Are they normal? Are they the same size? Are they the same duration? Are they the same shape? Morphology becomes important. And then check your PR interval, right? Is it below 0.20 seconds? A normal PR interval should be between 0.12 and 0.20 seconds. Any longer than that and you have a problem, there's an actual extra delay in the AV node that in many cases should not be there. And then the QRS complex itself. So the QRS complex shouldn't be any longer than 0.12 seconds. That's 3 of your small blocks, right? Anything longer than that indicates that there is a block or a holdup or some sort of problem causing the ventricles to depolarize and take longer than they should. Okay, so let's delve a little bit deeper into this, right? So let's go back into the actual categories. Normal heart rates, so rate first, should be between 60 and 100 beats per minute, okay? Any heart rate greater than 100 is tachycardia. Anything lower than 60 is bradycardia. Now, is that always significant? Not necessarily. Someone who's scared would be naturally tachycardic. Someone who is very athletic would have a naturally bradycardic rhythm, right? If they were a runner or a very well-trained athlete, if their heartbeat were 54 or 55 beats a minute, doesn't necessarily matter. That's just a result of their training. So how do we calculate rate? You can do this a couple of different ways. You can have the 6-second method where you check a 6-second strip. You count the number of beats in that, multiply it by 10. Bam, you've got what is happening in a minute. There are calculator rulers. You can use the R to R interval formulas. You can find these in your book. Not everyone uses them, but everyone should know them. And I'm not going to go through all of the math involved in it because I can't do math in an audio lecture with you, right? It's going to be very difficult to do that. So let's talk about the rhythm. So analyze the rhythm and measure the R to R interval across the strip. So is the R to R interval the same? Is it regular, right? So the QR, the tall wave, S, QRS, the tall wave is the R wave. And ask yourself, is this the same every time? Or is it different, but predictably different? Or is it completely unpredictable and completely chaotic in terms of the R to R interval? And all of those are predictors to what rhythm you are actually looking at. So other things, when you're looking at the P waves, okay, are they present? In some rhythms, P waves are not present at all, and they don't always have to be for someone to be walking, talking, and doing just fine. In the case of, we'll talk about junctional rhythms later. In junctional rhythms, there are no P waves. They don't have to be P waves. P waves can also be inverted, but that's another concept. We'll get into it later. So are they present? Are they regular? Are they the same size? Is there a P for every QRS? Are they upright or are they inverted? All these things are important in terms of the P wave itself. Okay, so in the next section, we'll kind of go through each individual wave and as it pertains to an arrhythmia. And I know this is going to feel like somewhat of an incomplete lecture, but trust me, it's laying the foundation for something that you can grasp in a little bit easier way. So just trust me and listen to the next one, and we'll delve deeper into it. And hopefully by the end of this, we will all have a complete understanding of how this works. Thanks for watching.